Welcome to this clinical explainer. We're going to break down the precise step-by-step workflow for mastering point-of-care knee ultrasound. If you've ever felt totally overwhelmed by the complex anatomy of the knee, or maybe you've been unsure if you're looking at a true tendon tear versus just some physical artifact, well, you're in exactly the right place. Today, we're taking those dense clinical guidelines and transforming them into a highly visual, completely reproducible system. To get us started, our agenda is broken down into 5 focused areas. We're looking at knee anatomy fundamentals, the 6-step scanning exam, common ultrasound pitfalls, identifying major pathologies, and finally, ultrasound-guided interventions. Let's get right into it. Section 1, Knee Anatomy Fundamentals. Essential structures. All right, let's dive right into the foundational anatomy. Think about it. At its core, the knee is this incredibly complex intersection where the distal femur meets the proximal tibia. As sonographers, we absolutely have to recognize the critical stabilizers on our screen. Anteriorly, you've got this massive extensor mechanism, the quadriceps femoris group, funneling right into the quadriceps tendon, basically encapsulating the patella, and then continuing on as the patellar tendon down to the tibia. And on the sides? Well, we have the major collateral ligaments, the LCL and MCL, acting as those crucial guardrails against varus and valgus stress. Now, think about how the knee protects itself from all that intense mechanical stress. It's actually amazing. We have these fibrocartilaginous menisci acting as the ultimate shock absorbers. The lateral meniscus is roughly O-shaped, while the medial is more C-shaped. And surrounding all of this are these highly vascularized fat pads, like Hoffa's fat pad infrapatellarly, along with fluid-filled bursae. These structures are literal lifesavers, reducing friction and letting everything glide smoothly during movement. Section 2, the 6-step scanning exam, a systematic approach. You know the saying, right? Proper preparation is half the battle, and it's so true here. Start by positioning the machine on your patient's right side. Grab a linear transducer set to a musculoskeletal preset. Your patient should be supine. And hey, here is a vital tip. Make sure the knee is slightly flexed, just about 20 to 30 degrees. Actually, popping a rolled-up towel under the knee helps a lot. This slight flexion perfectly tightens the extensor tendons, making them way easier to evaluate and seriously cutting down on imaging artifacts. Okay, so here's the absolute crucial point. We have to follow a highly reproducible, strict 6-step protocol. Why? Because sticking to a standardized chronological path means we literally never miss a critical structure. We start anteriorly, moving top to bottom, then we check the outside, the inside, and finally wrap up at the back of the knee. Let's break down exactly what we're hunting for in each step. For the first 3 steps, you're going to keep your probe longitudinal with the indicator pointing right to the patient's head. Step 1 is the suprapatellar view. Just fan through the quadriceps tendon and look deep to it for the suprapatellar recess. Then, step 2, simply slide down to the prepatellar view to check out the patella and the superficial prepatellar bursa. Finally, step 3, the infrapatellar view. You're just going to trace that patellar tendon all the way down to its insertion at the tibial tuberosity, making sure to note the dark hypoechoic Hoffa's fat pad right underneath it. Now notice how just a little tweak in patient positioning totally enhances your view. For step 4, the lateral view, have the patient internally rotate their leg just a bit. This lets you locate the lateral meniscus, which pops up as a bright hyperechoic triangle sitting between the femur and tibia, along with the LCL and IT band. Then for step 5, the medial view, externally rotate the hips slightly to find the medial meniscus and the MCL. Oh, quick pro tip for you. Use your zoom function and throw a chroma map on your machine. It'll really make any subtle tears in those meniscal triangles pop. Finally, we hit step 6, the posterior knee. You'll need the patient to flip over to a prone position with their leg fully extended. Change your probe orientation to transverse, keeping the indicator pointing to the patient's left. Deep down in the popliteal fossa, right beneath the medial gastrocnemius muscle, you are hunting for the totally anechoic circular popliteal artery and that highly compressible popliteal vein right beside it. Section 3, common ultrasound pitfalls, avoiding errors. All right, let's talk about the absolute #1 enemy of musculoskeletal ultrasound, anisotrophy. It's a fancy word, but by definition, it's just an artifactual loss of signal that makes a perfectly healthy tendon look dark or hypoechoic. It basically happens when your ultrasound beam strikes the tendon at an angle instead of being perfectly perpendicular. If you don't correct your probe angle, that dark area is going to mimic a tendon tear or a fluid collection, and boom, you've got a massive false positive. We definitely want to avoid that. Beyond anisotrophy, there are a few really common operator errors to watch out for. First off, applying too much pressure. Remember, the prepatellar bursa is incredibly superficial and super easy to obliterate. If you press too hard, you'll literally squeeze the fluid out of the way and end up reporting a false negative for an effusion. Because you need such a light touch over this bumpy, irregularly shaped joint, you have to compensate. How? By slathering on a really generous, thick layer of ultrasound gel to keep a good acoustic window. I know, it's kind of messy, but hey, it's a million times better than misdiagnosing an effusion. Section 4. Identifying major knee pathologies. Clinical findings. So, picture this. An athlete squatting a massive weight, and suddenly, they twist. What exactly happens when heavy axial load meets severe rotational force? Well, that specific combination is a perfect recipe for meniscal tears. On your screen, instead of seeing a nice, smooth, bright hyperechoic triangle, a torn meniscus is going to show irregular edges, or even dark, hypoechoic fissures slicing right through the meniscal cartilage. It's pretty unmistakable once you see it. Let's see how this visual evidence builds up when we're evaluating joint swelling. It is absolutely critical to differentiate between a simple and a complex effusion. A simple effusion, that's entirely anechoic, meaning it's pure black, just clear serous fluid. But a complex effusion is heterogeneous. If you start seeing internal echoes swirling around in there, you're likely dealing with hemarthrosis, blood in the joint. And even more critically, if you spot a distinct fat fluid level, where the echogenic blood sinks and the hypoechoic fat floats on top, that's lipohemarthrosis. Finding that strongly suggests you've got a hidden occult intra-articular fracture on your hands. Moving on to tendons and ligaments. When looking for traumatic tears of the MCL, LCL, or the quad tendon, you're looking for physical discontinuity, literally a dark, hypoechoic gap completely interrupting those tight, linear fibers, which is often accompanied by a localized hematoma. On the flip side, with chronic repetitive stress conditions, think jumper's knee, the patellar tendon won't actually be torn. The fibers are intact, but the tendon itself will be swollen, hypoechoic, and here's the kicker. If you turn on your color Doppler, it's going to light up with hyperemia from neovascularization. You know, ultrasound is also just phenomenal for diagnosing other common knee complaints. Say a patient comes in with posterior fullness. They've likely got a Baker's cyst. You'll see this as an anechoic fluid pocket basically escaping between the semimembranosus and medial gastrocnemius tendons. Suspecting gout? Look closely for the classic double contour sign. It's this superficial, bright line of urate crystals sitting right on top of the cartilage. And for teenagers coming in with anterior knee pain, Osgood-Schlatter disease clearly shows up as an extra bony shadow sort of pulling away at the tibial tuberosity. Section 5, Ultrasound-Guided Knee Interventions. Safe needle guidance. Whether you're draining an effusion with arthrocentesis or injecting some therapeutic medication, ultrasound guidance is absolutely the gold standard. And the workflow is really elegant. First, you locate your target fluid pocket using a long-axis view. Second, you just rotate your probe 90 degrees into a short-axis view. Freeze that screen and actually measure the depth to your target. Then, you insert your needle from lateral to medial using a flat, in-plane approach. Doing this ensures you can vividly see your bright needle tip advancing safely through the tissue, literally every single millimeter of the way. Which leaves us with this final thought for today. Now that you know the exact sonographic difference between a tricky physics artifact and a true structural rupture, how is this 6-step protocol going to change your next bedside diagnosis? Mastering this step-by-step ultrasound workflow directly empowers you to stop guessing and start actually seeing. It lets you deliver faster, more precise, and highly confident patient care right there at the bedside. Thanks for joining me on this explainer, and hey, keep scanning.